Okay, it's been after many requests that we need to have some OSCE based programs, because OSCE has been incorporated into DNB exams from this year. And of course, because of the COVID considerations, it's been modified to suit the present scenario as well. I think most of the exam going postgraduates have got direct information regarding how the OSCE is getting conducted, when they have to report to the hall, and what things they have to do before starting the OSCE. And as and when the OSCE starts, the questions will be broadcast right from the command center of National Board of Examinations, and the questions will appear before the candidate for a definite period only. But most of my friends asked actually how it happens, what are the kind of questions we have to prepare for OSCE, what are the advantages of OSCE, and how to tackle an objective structured clinical examination. So this edition, actually our idea is just to address that. This is going to be a short session because most of our exam going friends are busy with their preparation. But yes, we'll be discussing some tips and tricks, how to prepare and effectively manage your timing regarding the OSCE session. Dr. Anup?
Welcome, friends. So as Sanir sir has already mentioned, this is a exam preparatory session where you can gain confidence in approaching the OSCE exam. So this is entirely a new pattern of exam for all of us. So we have selected few scenarios. Like usually, this is the way the examiners also will select the scenario, and we can see within the stipulated time how you can solve those OSCEs. So that is the whole concept of this thing. And in the coming sessions, we will be coming with the OSCEs in different parts of anesthesiology. Just like the previously we were learning the equipments, the drugs, etc. The same way we will come up with more OSCE sessions, especially for the exam purpose.
Okay, I think in the beginning of this week, I had put 2 training videos so that the candidates can have an idea how to time their answers, like how it feels facing a question. And if the question has a full question, you will get 5 minutes in front of you to prepare the answer or write the answer. Or if the main stem has 2 branches, each branch will carry 2.5 minutes. So that was the idea of having that YouTube video in my YouTube channel, Anesthesia Tools. I think many of my friends have utilized that. The idea was to give an idea, give a rehearsal how this timing will be, because many people are apprehensive whether they can attempt these questions in the stipulated time. Again, there will be 25 stations as per the National Board of Examinations guidelines. Each station will carry 8 marks, but most of the stations will have sub-questions as well. The marks will be designated against the question. Maybe it's 4 plus 4 or 1 plus 3 plus 2 plus 2, like that. And the time for each station will be 5 minutes for 8 marks. And these are the snapshots of the OSCE trainer videos in the YouTube. And first we'll see how long is 5 minutes, because one of my friends who is about to appear for the exam next week asked me, 5 minutes is too short. And first we have to come out of this thinking, because 5 minutes is a pretty long time. If you know the mathematics, it's 5 into 60, that is 300 seconds. So how it feels, we'll see. I have put the timer here. So OSCE is objective structured clinical examination. Here the candidate will actually have an advantage of having your response in a written form, so that it's a structured question. The question may be split into definite sub questions. So you need to answer to the point. That's an advantage because you need not beat around the bush. Of course, that may be a disadvantage because if you don't know the answer, there is no credit for beating around the bush. So how do you plan? The moment you get the question, the timer also will be on the screen. So what you have to do is, now after this, you will realize that 5 minutes is pretty long time. We have not even exhausted 1 minute. Okay. So the first strategy is to keep cool. Okay, relax. Only a relaxed brain can bring out the best output. And once you are relaxed, think about what you have learned regarding the question and how to plan this question. Even if you spend 10-15 seconds for this, it's going to benefit you. Just because the timer is started or the question appeared, you need not jump over it and start answering. So you take a breath, relax, plan your answer, how you are going to put, whether it's in a diagram or as a table or as a flow chart, you plan. Because some of the questions will be short questions like oxygen dissociation curve, the relationship between PCO2 and the cerebral perfusion pressure. You already know the answer, or you are already familiar with it. So the best thing is to take a few seconds, plan your answer, and then write what is only required. Okay, if the question is about giving 4 courses, just write 4 courses and relax. Okay, so the 4 courses should be most significant and appropriate to the question. You should not write rare courses like causes of rightward shift of oxygen dissociation curve. You write how many numbers are required, maybe rise in H+ or acidosis, rise in temperature, rise in 2,3 dPg. That's it. You need not write too many things because you will get the credit. So now you can realize that even after speaking this much, we have exhausted only 2.5 minutes, which is a time for 4 marks. So you can have enough time to prepare your answer, then go for the response. Okay, so that you need not strike out the first paragraph, second paragraph. Your paper also should look neat and tidy, and it should be legible. If it is a management strategy, if you can put it in form of a flow chart, it's well and good. A comparison between 2 drugs, you write 2 columns, write one drug on one side, other drug on the other side, and put the values, whichever you know the best. So whatever you write, you should be sure. So you plan accordingly and proceed. Okay, even after speaking this much, remember we haven't exceeded the 5 minutes time. And again, you have an instruction that there will be a rest station after every 7 stations. 7 stations is 35 minutes of exercise, 7 into 5, 35 minutes. Again, you will get enough time to take rest, another 5 minutes. In this 5 minutes, the best strategy will be to forget what happened with the previous 7 stations. You are not going to get anything. You will not go to the question number 1, 2, or 3 or correct your answers. No. So just relax and think about the further next 7 stations. Relax, take nice breath, be calm and easy. Then you will be producing better answer for the upcoming 7 stations. Don't think about the past. What is done is done. That's it. Okay. So your thinking should be, yes, 7 stations over. Now I need to relax. I need not think about too many things. What's going to be coming in the next 7 or 14 or 21 stations? No, just relax, 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 so that your mind will give the best output. Okay. And after at 7 more 14 stations, you will get another 5 minutes rest, 21 questions, another 5 minutes rest. And after the OSCE session, filled answer sheets have to be checked for signature of the invigilator, roll number, and station number, and the invigilator will do the rest of the proceedings. You need not think about it. Once OSCE is finished, forget about it. Okay. Think about what you learned during the last 2 years or 3 years during your course. So those who have had a rigorous training, you have put in hard work, definitely the result will be there. Okay, just like a part 3, we'll again discuss some sample questions because there were many of my friends requesting for how to answer these questions or how these questions may be rephrased in different manner. Okay, so we'll see that. We'll see a few OSCE stations so that we can discuss. Any of my friends would like to participate in the interactive discussion can volunteer now. Your mic will be enabled and you can take the questions, because here you are not going to lose any marks. Okay,
Please
so now
raise
you
your
can
hand.
put the raise your hands option. So Dr. Divya.
Dr. Divya, I promoted you. You can just unmute and talk. Then,
Dr. Divya,
Divya, are you
Yes,
there?
sir. Yeah,
can you introduce yourself?
I'm Dr. Divya. I'm final year PG in RCC.
Okay, your exam going, or
I'm exam going.
and you're taking exam next week? Okay, Dr. Chedina, you're with us?
Chetana Goyal, please unmute yourself. We have promoted you. Or anyone else, or we'll have to randomly pick.
Okay.
Uh,
Okay. For us and for you, time is precious. We'll get along with the discussion, and as we get along, more and more people can join us.
Dr. Sumit, I have promoted you also. Sumit Mohan, can you just unmute yourself? Sumit? Sumit Mohan? Okay, for the time being, I think Divya will answer. Divya,
Okay,
are you ready?
fine.
Yes, sir.
Okay, fine. So here's the first station. Okay. So define capnography. The question is define capnography, which carries 1 mark, and see the diagram and identify the most common cause of the labeled change in the EtCO2. Second, enumerate uses of capnography for 4 marks, and what is the correlation between end-tidal CO2 and arterial CO2.
Okay. Capnography is a measure of carbon dioxide in the respiratory gases. And the most common cause for the labeled cause change in EtCO2 is the first A graph showing CPCR, and B graph showing there is a return of spontaneous circulation.
Okay, excellent. Okay.
Excellent, yeah.
And uses, we can confirm tracheal intubation.
Okay.
Then we can assess the patency.
Patency
Then,
means? I didn't get that.
Whether there is any block, any bronchospasm, or assessing the graph, we can assess different conditions.
Okay, the upslope will indicate so many things. It need not be the block or bronchospasm. We have to troubleshoot. Okay, that just gives an indication. Yes.
Then during cardiac arrest also we can use capnography.
Okay.
Then if it during mechanical ventilation, by looking at the capnography, we can know the EtCO2 level, whether the patient is hyperventilating or hypoventilation, etc. We can assess.
Okay.
Whether the patient is out of muscle relaxant.
Okay.
Then relationship between EtCO2 and PaCO2 is there will be a difference of around the PaCO2 will be higher than EtCO2, which is shown, and there will be a difference of around 4 to 5
Okay.
will be present.
Okay, so once we have an EtCO2 and a blood gas measured, you study the relationship, then you need not get arterial blood gas every time to check for the CO2 level. Okay.
And
the important use is to see that there is no accidental extubation.
Yeah,
especially
that's the
during
most important.
intubated patients outside the ICU or operating room for investigation or a transfer of patients. Okay.
Okay, sir.
Okay, fine. So writing this much, I don't think will take more than 5 minutes. The message from this is, when the EtCO2 is connected, because now the American Heart Association is recommending the use of capnography during CPR, because it will indicate the effectiveness of the chest compressions. Okay, what is the cutoff value?
Cutoff value, Divya,
Sorry, sir.
ACLS
Or
protocol.
effective CPR?
10,
No.
Okay, it should be definitely about 10.
more than 10, more than 10.
Yeah, okay. So if it is not there, either your chest compression is not there, you have to change the chest compressing person. Okay,
Okay, sir.
change the technique, or you have to do something about it. Maybe put a hard surface, make sure that there is the CPR board or hard surface
Okay, sir.
under the body. Okay, so this is a common question during the Viva. The differentiate between capnography and capnometry. Okay, capnography is the measurement and display of the EtCO2 and the waveform, CO2 waveform, and it's measured by a capnograph. Graph is the recording, and capnometry is the measurement and display of the value only. Here you can see the difference. Here only the value is displayed. Okay, and is measured by capnometer. Capnometer gives capnometry. Capnograph gives capnography. It's clear?
And 1 minute, by looking at this graph, what are the other use of capnography? It is obvious from the picture here. You can get the respiratory rate also
Yes.
from the EtCO2. And again, what are the types of capnography?
Volume capnography and time capnography.
Okay, then what are the other classification?
Mainstream type and the side stream type.
Side stream, yeah, excellent. And again in side stream, any two types? There is another
High flow.
yeah, micro stream. There is another method. It's almost same side stream capnography. And you should know what are the major difference and advantage and disadvantage of mainstream and side stream.
Okay.
So if the question is like draw a normal capnogram and label the part, explain the phases, can you do that? What is this phase 1?
Phase 1 shows the anatomical dead space.
Mm-hmm.
Phase 2 shows the
That's why there
alveolar.
is no CO2.
Yeah, no CO2.
Okay, fine.
The phase 2 shows alveolar gas and dead space.
Okay.
Then phase 3 is the elimination of carbon dioxide from the alveoli. And phase 0 is the inspiratory phase. And alpha angle and beta angle is there. Alpha angle is usually 100 to 110 and beta angle is 90.
Okay, fine. So while drawing the diagram, make sure you know definitely about the axis markings. It's not only the shape. Here it is millimeters of mercury, because we are speaking about EtCO2 in millimeters of mercury, and some monitors will give in percentage also. If you are labeling it as percentage, you should know the corresponding normal values. Okay, x-axis is the time. So most common mistake is you will forget what is in the x-axis, y-axis. Fine. So
Okay.
how about the first tracing, CO2 tracing?
It's a normal capnogram.
Okay, why is normal?
Because the EtCO2 is 35 to 45.
Yeah, okay. And the shape is acceptable. How about the second one?
Here the EtCO2 is more than 45. So it is hypercarbia and there is a loss of plateau. It's showing a shark fin appearance. And the respiratory rate is 24. Most probably it's a case of bronchospasm.
Okay. So we have to troubleshoot where the obstruction or increased resistance is coming. Okay. It may be due to bronchospasm, it may be due to obstruction in the expiratory limb of the breathing circuit or kink of the ET tube, or a presence of the foreign body in the upper airway, or partially kinked or occluded artificial airway. How about this one? Tracing
In this graph,
jumps to
EtCO2 is more than 45 and the respiratory rate is less 8. So it's hypoventilation, hypercarbia.
Okay, fine. So causes, possible causes?
Decrease in the ventilatory rate, decrease in the tidal volume, respiratory rate, and increase in metabolic rate.
Okay, and rise in metabolic rate. CO2 production is more either because of metabolic conditions or rise in body temperature, or even in something like a malignant hypothermia. Okay, so if you get this in OSCE question, you can easily list 4 or 5 like this, other causes of or possible causes of rising EtCO2. Sometimes along with that, they'll give the trend graph, not the EtCO2, the trend graph also may be given. How about this one, first one?
Here ETC is more than 45 and the baseline is raised and most probably it is due to rebreathing.
Okay. So rise in the baseline or appearance of inspiratory in CO2 is not a good sign. Either your soda lime is exhausted or you have to troubleshoot. Okay. So what exactly is the indication for change of soda lime?
Change in soda lime or if it is exhausted or there is a
Question is, when do you change soda lime?
if it indicates a color change.
Color change is one thing, but it is not fully reliable because over the weekend it can regain a bit of color and it will get easily exhausted in the initial hours of the day. Second one is appearance of inspiratory CO2. If it is more than 5, definitely you have to change. Initially, you can manage with the higher fresh gas flows. Okay. Next one is?
Here you can see there is a curare cleft, which suggests that the
Luckily here
patient is
it's
coming up.
labeled because we are asking question, they won't be labeled. It may be labeled as A, B, C or something, and you will be asked to comment. Okay. What does it tell you?
The patient is coming out of muscle relaxant. The patient is taking inspiratory efforts.
Okay. So spontaneous patient effort may be the reason. Okay. But this is a very late sign of neuromuscular monitoring. It is not a recommendable one because after recovering the train-of-4 ratio, it may be a little late. This appearance might appear a little late. So don't wait for the curare cleft to appear. So here, I think this we have already discussed. This is a EtCO2 tracing during the CPR, the rescuer change. Again, there is improvement in the EtCO2. Okay. So sudden increase, maybe next assessment phase, you will check for the presence of pulse. Okay. Just because you see a sudden increase in EtCO2, don't stop this. Continue CPR for that 2-minute cycle. And then during assessment, you have to anticipate that patient must have come to return of spontaneous circulation. So this is the mainstream and side stream ones. Okay, this again the picture or the video may be kept for the auscultation. Okay, the uses of capnography, confirmation of tracheal intubation, assessing the tracheal tube and tracheostomy patency and position, identifying or monitoring response to the treatment of bronchospasm, because initially there may be upsloping, it will come down as the bronchodilators start acting. Estimation of cardiac output, the area under the curve is an indication of the cardiac output. If you have noticed the EtCO2 trend, when the patient suddenly goes into severe shock or hypotension or cardiac arrest, you can see the EtCO2 also coming down and the area also comes down. Assessing the adequacy of chest compression during CPR, identifying return of spontaneous circulation during CPR. This presentation I will be sharing in the Telegram channel, so you need not spend time with the answers and all. So most of the answers I have tried to put. Okay, fine. Normally EtCO2 PaCO2 difference is 2 to 5. This is due to the dilution. Okay, alveolar dead space does not contribute to the end-tidal CO2 because the end of expiration, all the anatomical dead space volume has already emptied. So slight difference is because of the dilution. Okay, next station. Everybody else is ready?
Ashwini, I promoted. Ashwini, can you introduce yourself?
Yes, sir. I'm Dr. Ashwini, secondary DMB, sir.
Okay, fine.
And
We'll go to the question.
Sumit is also ready. And I think next question, Sumit, you can take. Sumit, can you introduce yourself? Dr. Sumit, can you introduce yourself?
You can unmute and talk.
He is already unmuted. Okay.
Okay, we'll proceed with the station. Okay, Dr. Ashwini, here is the station. You can note the timing also, 2.5 minutes. This is first part of the station.
Yes, sir.
Identify the ECG rhythm. Dr. Ashwini.
Yes, sir. It looks like torsade S pointers. The immediate step is IV magnesium, sir.
Immediate step.
You have to see the monitor. Everything is given.
What is the rhythm and
Oh.
what is the immediate step?
Defibrillation.
Immediate step. ACLS, you should be
CPR,
very
sir.
thorough, okay?
CPR, sir. CPR with defibrillation.
Yeah, this
Sure.
is a pulseless scenario.
Yeah.
Okay, you have to identify. It's a cardiac arrest scenario. It's only not an arrhythmia scenario. It's a cardiac arrest scenario. It's a VTO or VF without pulse. Okay, so immediately, if this is a witnessed event, what is the first step?
CPR, sir.
Okay.
Just
Witnessed arrest.
the patient is in the OT. You are seeing the like in monitor the rhythm. You have defibrillator also in your side.
There
You
should be crash cart available, no, inside the theater.
Yes, sir.
So what will you do?
CPR followed by first awake the patient, sir, then call for help, then check for the
It's not
pulse and
responding.
respiration.
Patient is not responding.
Then
Obviously, it's in
yes, sir,
arrest
then
state.
starts call for help, then check for the pulse and the breathing, then start CPR. Then if it's an pulseless VT, we can ask for defibrillation, sir, and give CPR with breaths at the ratio of 30:2.
Mhm.
Secure the airway, don't stop CPR in between.
Mhm.
And during defibrillation, 360 joules if monophasic and 200 joules if biphasic.
Mhm. Okay.
Then again look for pulse and rhythm.
Okay. If I am answering, I would say this is ventricular fibrillation without pulse. This is a cardiac arrest scenario. The answer to this scenario is immediate defibrillation because the examiner says it's a witnessed VF or pulseless VT. Okay. Immediate, the definite answer is immediate defibrillation. But while the defibrillator is getting arranged and charged, you have to start CPR with chest compressions and ventilation. And then once the earliest opportunity when the defibrillator is charged, you discharge or do the defibrillation, which should be backed up by 5 cycles of chest compression ventilation. Okay.
Yes, sir.
Okay, because here is a scenario where you have the arterial line connected, that is showing flat line, pulse oximeter is showing flat line. So there is maybe the scenario is inside the ICU or inside the operating room with monitors. Okay, fine. So what is the logic in giving the chest compressions prior to defibrillation? What is the recommendation from 2015 guidelines?
Just to improve, to provide some output from heart, sir. Heart is just fibrillating, but the meantime, you can just provide the mechanical support to the heart.
Okay. The more you wait without chest compression, the coronary perfusion is not there. Okay. Even after you start chest compression, it takes at least 4 or 5 effective chest compressions to give effective coronary perfusion. And only if the coronary musculature is adequately perfused and the ATP stores are getting repleted, your defibrillation is going to be successful. That's exactly the idea of asking you to continue CPR for another 5 cycles or 2 minutes. So you check for the defibrillation success only after 2 minutes. Okay. The stacked defibrillation recommendation is not there now. You give one defibrillation of 200 joules with a biphasic defibrillator, or if only monophasic is available, you give the 360 joules defibrillation. And next, what you expect is the myocardium should pick up the activity. The fibrillating activity should stop and some perfusing rhythm should come. So when the perfusing rhythm is expected to come, you have to load the myocardium with the ATP stores. That's the idea of backing up defibrillation with the chest compressions. Okay, are you getting my point? So if the next
Yes, sir.
assessment, if patient is still in pulseless VFVT, what's the step?
Continue CPR, sir.
Yeah, I'm telling after 2 minutes of CPR during the assessment phase, every time assessment phase is not less than 5 seconds, not more than 10 seconds. During that time, patient is still in VF or VT without pulse.
Again, defibrillation can be given, sir.
Okay.
Should be.
Any change from the initial defibrillation?
Dose can be up to 360 joules. We can go.
That's a different thing because you might get only one defibrillator, either monophasic or biphasic. You have defibrillated the second time. Again, your colleague or the team member continues with the chest compression and ventilation. So as a team leader, what is your next order?
We can go for pharmacological therapy, sir.
Yes. Which one
If
you
it
will
doesn't respond to defibrillation, we can go for antiarrhythmics, amiodarone, and lignocaine, sir.
No, you have to be clear because the first one you are instituting is 1 milligrams of epinephrine. Okay. 1 milligram of epinephrine followed by
Every 3 minutes.
Yeah, then afterwards, every 3 to 5 minutes, you continue with 1 milligram of epinephrine. Again, after that second set of CPR, 2 minutes of CPR, again during assessment, if the VF pulseless VT is persisting, then immediately after defibrillation, the third defibrillation you start on antiarrhythmics. So which one you will prefer, amiodarone or lignocaine?
First lignocaine, sir.
First lignocaine, because most of the examiners will expect AHA recommendation. There is no doubt in that. It should be amiodarone 300 milligram IV push. Okay, there is no question of slow infusion. Cardiac arrest scenario, you have to give 300 milligrams of amiodarone IV push. Okay, then continue. If amiodarone is not there, probably you can opt for lignocaine intravenous preparation 1.5 milligrams per kg. Again, if it still persists, right from the second defibrillation, you should be targeting that differential diagnosis 5H and 5Ts. Okay, just like in your OSCE, that 5 minutes is a good enough time to evaluate what is what, which is the likely cause. Okay, so if the first dose of amiodarone is not working, after the next assessment, you give 150 milligrams of amiodarone. And then if it is still persisting, you can opt for an infusion of amiodarone. Meanwhile, every 3 minutes after the first epinephrine will keep on continuing. Okay. So this algorithm part, you should be clear. So rhythm, shockable rhythm, VF or pulseless VT, first is shock. But while you prepare for the shock, do chest compressions. And after the shock, CPR for 2 minutes. Meanwhile, you secure intravenous or intraosseous access. Then if rhythm is still shockable, then give shock, continue CPR for 2 minutes. During chest compression, you have to give epinephrine and start it every 3 to 5 minutes. And this is the first opportunity where you consider advanced airway followed by confirmation by capnography, but it is not mandatory. Okay. If it is still there, after the third shock, CPR for 2 minutes. During that chest compression time, when the circulation is somehow artificially supported or maintained, you give the antiarrhythmic, amiodarone or lignocaine. So you have to consider reversible causes. Did you get my point? You have to be clear.
Yes,
because sometimes the examiner will give a scenario that your colleague has given first shock, CPR is going on, IV line is present, you check, rhythm is still shockable. That means you have to come up to this phase. There should not be any confusion. Here you should say after the defibrillation, you'll continue, back it up with the chest compression 30:2. And during the chest compression, I'll start the first dose of epinephrine and back it up with the epinephrine repeat boluses every 3 to 5 minutes throughout the cardiac arrest phase. Okay. Suppose examiner says after the third shock, you are coming into the scene. Then say after the shock during chest compression, I'll start on antiarrhythmic. Amiodarone 300 milligram is my first bolus dose. Okay. So there should not be any, you will not be inviting the examiner for too much questions. Okay, I'm not going into the details of CPR. Whenever you are asked about the CPR, you don't have any margin to err. The buzzwords push hard and push fast, minimize interruptions in compressions, avoid excessive ventilation, change compressor every 2 minutes or sooner if fatigue. If no advanced airway, continue 30:2. If advanced airway is there, what is your ratio, compression ventilation ratio?
30:2.
With advanced airway.
Respiratory rate should be 10 per minute or 11 per minute continuous.
Okay, 10 per minute, one breath every 5 to 6 seconds, and the compression will continue uninterrupted with the at least 100 per minute, but not more than 120 per minute. Okay, all these buzzwords should come in your answer, just like our kids tell the nursery rhymes. Okay,
Yes, sir.
then other things, biphasic, the shock defibrillation doses 120 to 200 joules. If unknown, you don't know whether it is monophasic, biphasic, dial the maximum joules. Okay, monophasic, it's 360 joules. I think the defibrillators from before the 2000 year is monophasic. And epinephrine dose, you should not miss out 1 milligram, and the frequency is every 3 to 5 minutes. Amiodarone dose, first dose 300 milligram bolus, second dose 150 milligrams. This is an alternative choice, lignocaine, IV or intraosseous. First dose 1 to 1.5 milligrams per kg, second dose half of it, 0.5 to 0.75. Is it clear?
Yes,
So if I ask you, if you are unable to find an IV access, what's your next route of choice?
Intraosseous, sir.
Intraosseous. Okay. So reversible causes, you should be thorough. I'm not going into that. And return of spontaneous circulation indications are return of pulse and blood pressure, abrupt sustained increase in end-tidal CO2, typically more than 40 millimeters of mercury, and spontaneous arterial pressure waves, if, like in our scenario, patient has intra-arterial monitoring. Okay. This is another diagram you can draw easily during your OSCE station. So it's better to spend a few minutes learning how to redraw this diagram. It's very simple. Okay, so start CPR, give oxygen, attach monitor defibrillator, check rhythm, if VFVT, shock, and continuous CPR. Then monitor CPR quality, continuous CPR, it will continue. Next time you have to go for IV or IO access, epinephrine, amiodarone, consider advanced airway, treat reversible causes, and in case of return of circulation, you switch over to post-cardiac arrest care. Okay. Regarding amiodarone and lignocaine, 2018, some clarifications have come. Amiodarone and lignocaine. Amiodarone or lidocaine may be considered for VF or pulseless VT, that is unresponsive to defibrillation. These drugs may be particularly useful for patients with witnessed arrest, for whom time to drug administration may be shorter. Okay.
Yes, sir.
Again, regarding magnesium, routine use of magnesium for cardiac arrest is not recommended in adult patients. This is a class 3 recommendation. Okay. May be considered for torsor depoinders. That is class 2B recommendation. Wording of this recommendation is consistent with the HS 2010 guidelines onwards. So, you know, if the examiner puts you a query regarding amiodarone or lidocaine, this is the answer. Regarding magnesium, if you feel the ECG points to torsor depoinders, yes. Otherwise, no empirical therapy with the magnesium sulfate. Okay.
Sir, 1 minute. Can you just describe the use of magnesium or why magnesium is not given? Divya or anyone else? Now, why the 2008 that guideline was changed? Basically, they have compared few. Yeah, please. Someone is answering. Yeah, basically the magnesium has a role in prevention only, like especially when there is a QT prolongation, it can prevent a polymorphic VT. But once there is a polymorphic VT, the trials have shown that it cannot attain like an arrhythmia reversal to a ROSC or like the duration of cardiac arrest. Both it cannot reduce. That's why it is not used as a drug during the CPR. But if it is prolonged QT interval later on to prevent further polymorphic VTs, you can use that. And you should know the dose, the uses of magnesium sulfate as well, that we will discuss later on during the drugs.
Okay. Fine. And one more thing, a clarification regarding targeted temperature management. Prashni, you can comment on that. What is targeted temperature management in post-resuscitation care?
Targeted temperature management is the care of the patient after ROSC, sir. It should be targeted around 32 to 36 degrees, and hyperthermia should be avoided. Hypothermia is not recommended, but hypothermia should be avoided, sir. It's around 32 to 36 degrees.
Yeah, that's a point, because hyperthermia definitely not accepted.
Then
the temperature
32 to 36, now we don't, he will explain that. So if you don't want hypothermia, so better you aim for a normothermia. Even if you are going for a hypothermia, you don't need a temperature something around 32.
Okay,
Yes.
so that's a change in the recent guideline. Okay, this is important for post-cardiac arrest patients. Recommend active control of patient's core temperature be achieved as soon as possible, with the control maintained for at least 48 hours. Okay, clinical data strongly supports avoiding fever for at least 48 hours following cardiac arrest. This actually is applicable to post-cardiac arrest patients not responding to verbal commands. Okay. And up to date, they have mentioned they suggest using 36 degree for 24 hours in uncomplicated patients who have moderate coma or some motor response, no malignant EEG patterns, and no evidence of cerebral edema or CT scan. And they suggest using 33 degree for at least 24 hours when coma is deep, that is absolutely no motor response or brainstem reflexes, malignant EEG patterns like epileptiform appearance, or early CT scan changes suggesting development of cerebral edema. Okay, only for those cases, we need to bring down the temperature further. Okay, how will you give defibrillation, Dr. Ashwini?
So first we have to power and charge the defibrillator, sir.
Okay.
Then attach the pads. We have to ask oxygen should be stopped. I mean, while defibrillating, and we clear all the persons around the patient should be clear, and there should not be any alcohol or any other around the patient, fluids around the patient. Then we have to give the shock, sir.
Okay, maybe in the skill station, you may be curious regarding the practical aspects, like how will you give defibrillation for a patient rescued from drowning, or a hairy chest, a patient with pacemaker and all. This is given in the AHA leaflets. Okay, thing is, this identification of this equipment, you can't miss out because you have been using it many times. And how to take out the paddles, you should be clear. Okay. Each manufacturer technique is different, but basically the method is clear. So you power on, you need not attach the ECG electrodes for defibrillation purpose. You can go do it with the pads. Where do you place the paddles?
Anterolateral, sir. 1 to 2 centimeters medial to the upper is second intercostal space, and the lateral pad is 5th intercostal square anterior axillary lines.
Okay, maybe right infraclavicular region and towards the apex. Kids,
Yes,
it maybe anteroposterior is also accepted. And what is the difference between pads and paddles?
paddles we see in the stations where there is defibrillator in the railway station, also they are mostly biphasic, sir. And the paddles we see in this defibrillator.
The sticking pads have some advantage because you can be hands-free, and you need not interrupt the chest compressions, and the contact is more consistent when you attach or stick the pads on the chest. Paddles, you have to give adequate pressure. Maybe the chest compressing person will have to interrupt more. The interruption time will be more, and you have to apply jelly and give good contact, mechanical contact, then activate the charge button, and before you discharge, you announce to the team, to everybody, I am clear, you are clear, all are clear, and then activate the defibrillator button. What is the difference between cardioversion and defibrillation?
Cardioversion is synchronized, sir, and defibrillation we no need to synchronize with the ECG.
Okay, no need to synchronize, and you can't synchronize also in aventricular fibrillation. Okay, so this is cardioversion is synchronized to the QRS complex. Defibrillation is unsynchronized. Cardioversion terminates arrhythmias by delivering a synchronized shock that depolarizes the tissue involved in the re-entrant circuit. Okay. So energy selection. How do you select the energy? For atrial fibrillation, what is the energy? Atrial flutter.
For atrial fibrillation and flutter, if it's in biphasic, 50 joules we start with, sir. And then for the second,
I'll come to that later because we have to rush through. What are the steps of electrical cardioversion? If patient suddenly throws a new onset SVT and patient is becoming hypotensive, complaining of chest pain, dizziness, sweating.
The same as defibrillation, but it should be synchronized with the ECG, sir.
But to the patient, because patient is conscious. Pulseless scenario is different.
So here it's an the patient will need discomfort. Sedation is required in cardioversion, sir.
Okay, so I'll tell you one mnemonic kind of thing. You have to take a verbal consent. Okay, need not be a written one.
Yes.
Secure a cannula, which is compulsory because you have to give sedation and patient can switch over to cardiac arrest or any other scenario anytime. You have to have the crash card beside the bed. Okay, consent, cannula, crash card. Okay, now you think about the 3S. You have to give sedation, press the sync button on the defibrillator, and then give the shock. So there is CCC.
Sir, if the patient is not on NBM, sir, how can we give sedation, sir?
Pardon? No, when somebody is in
NBM status.
You can't wait because some of the cases you will be committed to proceed because the patient is becoming hemodynamically unstable. Okay, you can't keep the patient NPO for 6 hours with the hemodynamic instability. So that risk you have to explain and proceed. And if you are seriously concerned about aspiration, then you have to secure the airway and proceed. Okay, because tachyarrhythmias, when it is not significant, there is sensorium is fine, hemodynamically fine, no ongoing signs of chest pain, no sweating, no signs of cardiogenic shock, then you can wait. You can give an antiarrhythmic and wait for a cardiologist to intervene. But if the patient is having significant tachyarrhythmia, that means hypotensive or signs of cardiac shock, cardiogenic shock, ongoing chest pain, altered sensorium and all, you have to proceed with the synchronized cardioversion. Okay, how much to give sedation is case-to-case basis recommendation because there is no recommendation saying that you have to give this much propofol, this much midazolam and all. Okay, opioids will be a good enough choice. And how much energy? So you have to be clear about this. Atrial flutter, biphasic 50 to 100, monophasic 100, atrial fibrillation 120 to 200, monophasic is 200, when VT with the pulse 100 joules, pulseless VT and VF which is 200 joules. Okay, so you have to learn this because you might get targeted question in the OSCE station. Select the energy level for atrial fibrillation like that. Okay, you know how to identify the atrial fibrillation ECG?
Yes.
How will be a ECG with atrial fibrillation look like? Salient features.
Varying RR interval, sir, with ventricular rate more than 150 with absence of P
for fast AF. Okay, absence of P waves because maybe you can put it as fibrillating P waves. That's why you are not unable to identify the P waves. Okay, SVT also P waves are actually hidden in the QRS complex because the rate is high. Okay, again, I have mentioned already, how will you manage cardiac arrest victim after return of spontaneous circulation? It's about you putting the algorithm. You need not write in paragraphs. If you know the algorithm, you can write the algorithm. You can save time. Okay, It's always beneficial to learn the algorithms from ACLS algorithm, definitely yes. Okay. So return of spontaneous circulation, you go by ABC, airway and breathing. Maintain oxygen saturation above 95%. 94 is absolutely fine. Advanced airway confirmed by waveform capnography. Do not hyperventilate. So this is with regard to airway and breathing. Now coming to circulation. If the systolic blood pressure is less than 90 millimeters of mercury, you can give an IV bolus or start a vasopressor infusion, maybe noradrenaline, and consider treatable causes. Obtain 12-lead ECG. Why we are obtaining 12-lead ECG?
Any rhythms?
Yeah, basically we are worried about ST elevation MI, so that we can immediately take the patient to cath lab. Next, assess the disability or sensorium, whether the patient follows verbal commands. If patient follows verbal commands, you have to decide whether patient should go to the cath lab or to critical care, depending on a finding in the ECG whether there is STEMI. If patient doesn't follow commands, then you have to start targeted temperature management. Still, by the time 12-lead ECG comes, there is indication for STEMI, hypothermia and angioplasty will go hand in hand. So after initiating targeted temperature management, take the patient to cath lab. After the procedure, take the patient to advanced critical care or ICU. Is it clear? So ROSC, airway breathing, circulation, disability. In circulation, you will be checking for 12-lead ECG, and disability, you will be checking for the neurological status, whether the patient follows command. These two things are the factors determining whether the patient will go directly to ICU or through the cath lab, or whether patient requires targeted temperature management. Is it clear?
Yes.
Okay, so when you are given a scenario during cardiac arrest, suddenly the examiner says there is a jump in the ETCO2 and patient has attained the ROSC, your memory, the algorithm chart should turn to this page. Then things are easy. Okay, I know when during my PG days, whenever examiner says pulses come back, I used to be in distress, because if pulse is not there, I can at least tell about 30:2. Okay, fine. Who is attempting the next question? Dr. Divya?
Yes, sir.
You're still with us? Okay. Yeah, fine. Thanks. You can proceed. Identify the finding in the chest X-ray. 18-year-old boy presenting to emergency room with sudden onset of left-sided chest pain and breathlessness.
This is a case of chest X-ray, PA view.
No, this station you need not describe. Like,
Okay,
straight
this
away give
is
the
a
diagnosis. It's only for 1 mark.
pneumothorax.
Yeah, maybe you can put the points in favor of your diagnosis also.
In left side of the chest, here you can see an area with no bronchovascular markings, and with it is hyper and showing black
Hyperleucinemia.
hyperleucinemia.
Okay.
So it suggests
Collapsed
pneumothorax.
lung margin. Okay.
Collapsed lung
Now,
margins.
how will you manage in the emergency room?
Immediately we can put a needle thoracotomy and let the air out,
Thoracostomy.
or thoracostomy, then followed by if ICD can
No,
be
after
inserted.
seeing the X-ray, you have to check whether the patient is in distress. Try to auscultate to confirm the diagnosis. Maybe ultrasound. Ultrasound is nowadays the tool in the emergency room.
Okay, sir.
Okay.
You have to see the hemodynamic stability as well. If the patient is
Okay, sir.
hemodynamically stable, saturation is maintained, you can go for a like intercostal drainage itself. If patient is in severe distress, hemodynamically unstable, you go for a needle decompression.
Okay.
Needle decompression is just buying time for ICD insertion. Okay, it's not going to be the solution for the problem. Okay.
Okay, sir.
Fine. So usually nowadays you can expect questions from the ultrasound findings. So can you describe the ultrasound findings suggesting pneumothorax?
Here we can say there is no movement of the pleura, so it shows like a seashore sign.
Mhm. For 2 marks, what all things you'll write? That is our discussion today. Okay.
No sliding of pleura will be present.
Lung slide will be absent.
Lung
Okay.
slide will be absent, and
What are the other findings? USG finding, pneumothorax, absent lung slide, then 2 more.
then
In yeah, this is one. In M mode,
there will be stratosphere sign,
or but what is it otherwise called? It's called a barcode sign.
barcode sign.
And then last one.
The absence of lung point. Lung
Presence.
sliding is absent.
That you
Lung
told
point,
already.
what is that? Absence or presence? If you have
Presence of lung point.
yeah, presence of a lung point. Yeah.
So these 3 points, if you can write, you can save time. Okay.
Okay,
So
sir.
this should be an expected question. When the question comes, you throw this answer. That's it. You save time for other questions. Okay. Fine. So these are the images of USG in pneumothorax. You can even get ultrasound images in anesthesia OSCEs also. So you should be familiar with it. Okay. How does a lung point look like, and absence of lung sliding? These things you should be familiar. So this is an indirect way of testing your skills. Okay. So you have to expect this, even the video clippings of ultrasound in your OSCE station. So what is triangle of safety? Where are you going to put the intercostal drain?
We are putting it in the lateral, means axillary line. It's bounded by anteriorly by pectoralis major, then apex of the axilla, then posteriorly by the latissimus dorsi, and inferiorly by the fifth rib.
Okay. So lower border of the fifth intercostal space, actually up to the fifth intercostal space, lateral edge of pectoralis major, and behind lateral edge of latissimus dorsi. So can you tell something about underwater seal?
In underwater seal, there is a chamber in which we will insert the tube, and the water column will be around 2 centimeter above the tube, and on inspiration the water column
Tube
will move
be at least 2 to 3 centimeter below the water
below the
level.
water level.
Mhm.
On inspiration, the water column will rise, and by assessing the seal, we can know whether the lung has expanded or whether there is any leak is present.
The movement will only tell you there is a gush of air out of the chest cavity. Re-expansion we have to assess through the auscultation,
X-ray.
ultrasound, or chest X-ray. Okay.
Okay.
If it is blocked, you won't get this movement. Probably the lung is fully expanded and the area is collapsed. Then you have to go for reviewing of the clinical findings. Okay, don't depend on one finding. Okay, one more question you can take, I think. 21-year-old woman presents to emergency department with 6-hour history of worsening of breathlessness and wheeze. She has a history of asthma with 2 previous exacerbations requiring hospital admission. She now feels very breathless and is obtaining no relief from her salbutamol inhaler. Okay, pulse rate is 115 beats per minute. Respiratory rate is 30 beats per minute. Blood pressure 120/80, saturating 96% in room A. Peak expiratory flow 160 liters per second. Predicted was 400. So here's the blood gas report for you. How will you manage this case? 5 minutes question. The sub questions are: interpret ABG report for 4 marks and mention the steps for immediate management.
Here the pH is 7.38.
Okay.
The patient is in acidosis, and
7.38.
normal, around
Around
normal.
Yeah, somewhere around the normal range. Okay. PCO2.
PCO2 is 43.
Mhm.
So hypercarbia. There's retention of some carbon
Not
dioxide.
much. Not much. 40 to 43. The rise is not very much.
PO2 is decreased 76.
Yeah. Okay. Fine. Bicarb, it's 24. Are you
24.
happy? Base excess of minus 1.3.
Base excess. Metabolic
Okay.
acidosis.
Okay, my friends, listening to this discussion, you can also write in your diagnosis in short. Anup you'll take us through this blood gas interpretation.
Yeah, and again, this scenario, Divya, the history is very important. This is a 21-year-old woman, she's a non-asthmatic presenting with this ABG. So asthmatic when presenting with a slight increase in CO2, that has a too much clinical significance. If it is a COPD patient or even a elderly patient, the interpretation might have been different.
Okay.
So that is a different thing, the clinical aspect. The ABG aspect also you should know how to interpret stepwise. And those who are attending, please go back and view our webinar campus video on ABG interpretation. You all should be very familiar with the stepwise approach of ABG interpretation. So once you go with the stepwise approach, you will not miss any points.
Okay, especially if this comes in your Viva station, it will be impressive if you go step by step. First, you check the pH, whether it's acidotic range or acidemia or alkalosis is there. So here you can't label it as acidemic or alkalemic because it's 7.38 only. Okay, somewhere in and around 7.35. Then if it is an acidosis, probably we should have checked the PCO2 first, whether PCO2 can explain the acidosis. Okay, here it's not the case. If PCO2 cannot explain, then you go to bicarb to see whether metabolic thing can explain the change in pH. Okay, there is seven-step method we have described, and then you see whether the change is corresponding to the change in pH. Here the scenario is slightly different because pH is in the normal range, PCO2, bicarb, all are in the normal range. As Dr. Anup mentioned, we are discussing about a young lady with history of asthma. It's an exacerbation of asthma. Okay, what you expect in asthma is hyperventilation and trying to breathe out. So usually the CO2 should have been less. Of course, the PO2 is less. There is mild hypoxemia.
And again,
The
even
thing
a
is,
normal CO2 in an asthmatic patient is significant. That indicates the patient is going for a impending respiratory failure. Usually, they will hyperventilate and wash out the carbon dioxide. So even if you get a normal CO2 in an asthmatic patient, that indicates the patient is going for a impending respiratory failure, and you should be ready with your intubation things.
okay. So that's the message. Though it's an OSCE question, we also want to convey this message. Seeing this ABG alone, you should not say it's normal because now we are into a life-threatening condition. So increased respiratory rate and effort, alveolar ventilation goes up, low PCO2. And once the patient is unable to overcome the airflow obstruction, begins to tire out from the effort of breathing, then actually PCO2 tends to increase. Now this ABG shows that this poor girl has gone into this phase. So this is a life-threatening attack. So that is the clue you have to pick from an apparently normal looking ABG value during an asthma exacerbation. So next thing you are going to see is maybe a hemodynamic collapse and respiratory failure. So how do you manage such case? Would you keep on giving bronchodilation?
will give 100% oxygen, then we can intubate the patient and maintain ventilation.
Okay, fine. If you happen to see this patient in the emergency room, you talk to the patient and or relatives and immediately get the patient shifted to ICU, arrange an ICU bed and prepare for acute severe asthma, life-threatening management, intensive care management. Patient requires close monitoring, and most likely patient will require mechanical ventilation also. Okay, and repeat blood gas to see the trend, how the parameters face off when you give secure the airway and institute mechanical ventilation support. Of course, your bronchodilation, dilator therapy, and if the sepsis is the initiating cause, you have to start correcting the primary cause. Critical care, anytime, anywhere, correcting the primary cause is going to get the patient back. Supporting care and correcting the physiology just buys time for your drugs to act. Okay.
Yes.
So this ABG is not an easy ABG. If you hear by phone, it might look like an normal ECG, normal blood gas. Okay. So ABG interpretation, clinical features is very important. If without these clinical features, probably I can put it as mild hypoxemia, probably start on oxygen supplementation. That's it. But given the history, it's a life-threatening event. Okay. So I'm not going to repeat it because we'll spend more time. Our video is available in our YouTube channel. You can go through the video again. We have mentioned it's a 7-step approach. First step, whether patient is acidemic or alkalemic. Second step, determine which is the primary insult. Then whether it is acute or chronic. Third step, check with the change in pH, whether it accounts to the PCO2. Check for the extent of renal compensation. We have some rules of thumb. Okay. During Viva, probably rule of thumb also might be asked. And whether it's a metabolic, check the extent of respiratory compensation. Check the anion gap in metabolic acidosis, and whether it explains the change in bicarbonate. So we will have a comprehensive view of the blood gas. One more thing, ABG is not only about metabolic and respiratory, it also indicates the oxygenation ventilation status as well. Okay. So now next station, who is going to help us? A new person can come up. Dr. Apurva, I think.
Apurva, can you just raise your hand? Yeah, Apurva. Apurva, you can unmute and talk. Apurva? Yeah.
Yes, sir.
Yeah, okay. So you are ready?
Yes, sir.
We'll do one exercise. It's compare and contrast. Okay. We will not be discussing all the drugs. Just for an example, if you are asked to compare and contrast 3 drugs in
Yes,
front of you, lignocaine, bupivacaine, ropivacaine. And the second
Yes.
part of this question is outline the management of local anesthetic systemic toxicity.
Yeah.
Okay.
So lignocaine, all 3 are amide and local anesthetics. Lignocaine has a more CNS toxicity compared to ropivacaine. It is less cardiotoxic. Bupivacaine is more cardiotoxic. Ropivacaine is less cardiotoxic and it is an S enantiomer of bupivacaine. Lignocaine maximum toxic doses without adrenaline, it is 4.5 mg per kg. With adrenaline, it is 7 mg per kg. Bupivacaine without adrenaline, it is 2 mg per kg. And with adrenaline, it is 2.53 mg per kg. Ropivacaine 2 mg per kg and 2.53 mg per kg.
You have
CC
a
by
reference for this with adrenaline for bupivacaine, ropivacaine?
bupivacaine and ropivacaine 2 and 3, sir.
Yeah, okay. What's your reference?
Sorry, sir.
What's your reference? Like which source you are quoting? Okay, leave it. You'll go
Yes.
ahead. Yeah.
Yes, CC by CNS ratio of lignocaine is 7, and the CC by CNS ratio of bupivacaine is 3, and ropivacaine is more than bupivacaine.
Mhm.
Okay. Um, uh, mm, yeah,
Okay.
lignocaine has a shorter duration of action, up to 1 hour. Bupivacaine has about 120 to 180 minutes of duration, and ropivacaine has 100 to 120 minutes of duration. Uh, and lignocaine and bupivacaine are vasodilation. They have a vasodilatory action, whereas ropivacaine has a vasoconstriction action.
Are you
So there
sure?
is less systemic absorption.
Are you sure? Ropivacaine has vasoconstriction action.
Yes, sir.
I thought
That
it's
is why it has.
regarding vasodilation, it's the least vasodilatory.
Okay.
Okay.
Um,
Okay, fine. So one good thing I noticed was you are not describing one and coming to the second one. Okay, why that happens most likely, like one person will start describing on lignocaine and forget about the second one. It's a good habit to compare these 2 or 3 given together, like the class of drug. Here common things are there. Amide group, they are all metabolized by hepatic metabolism. Okay, so unless you are prepared, you won't be able to give a written table format of answer like this. But lignocaine, local anesthetics, you should be familiar with a comparison chart on your own. Okay. Similarly, you should have a comparison chart between the IV induction agents, between the volatile agents, maybe isoflurane, sevoflurane, and desflurane. You should be able to compare. That
Yes.
comparison you can prepare in advance, and even if you spend some time, if you get a question like this, you can save time also. But you have to prepare. Often you can't tell, like this relative potency 144, onset lignocaine, fast onset bupivacaine, and other one ropivacaine, medium onset. Okay, and PKA, protein binding, relative lipid solubility, volume of distribution, all these things you can prepare and keep. Okay, the vasodilatation, ropivacaine is least vasodilatation.
Okay.
Again, in toxicity you can comment, and again you can mention regarding the preparations. What preparation is shown during Viva, you can mention only the preparation. Probably the examiner might prompt you to other preparations. What are the other preparations of lignocaine? Lignocaine, other preparations apart from
Yes.
lignocaine?
So 1%, 2%, 5%, 10%.
5% of what?
5% lignocaine was used for intrathecal administration, which led to cauda equina syndrome. So they have stopped using it.
Okay.
And
Then?
10% lignocaine spray.
Mhm.
And lignocaine is also a part of EMLA mixture, 2.5% of lignocaine with 2.5% of prilocaine. And lignocaine jelly.
Okay. So for an OSCE
and
session,
4%
you can
lignocaine.
write some 8 to 10 preparations, right?
Yes.
Okay, you can have a 2% lignocaine solution, 2% with epinephrine, and you can have 1% solution.
4%.
2% jelly is there. Okay, then lignocaine with 2% with 1 in 80,000 for injection in a cartridge dental people are using. 4% topical solution is there. 5% hyperbaric for intrathecal use. 2% viscous. 3.5% ophthalmic gel. 3% with hydrocortisone cream. and even transdermal patch is there. 10% suppository is there. Not every preparation is available in India. And xylocaine spray is there. Can you elaborate a little bit on xylocaine spray, lignocaine spray? One more preparation is the intravenous preparation of xylocaine, lignocaine. Okay,
Yes,
we
sir.
call it as Loxicard or Xylocard.
Yes,
So
sir.
10% spray, can you comment on that?
10% spray, we can use it for the
So what do you
awake
mean by
intubation.
10% spray? What is the
Each
10%?
puff contains 10% of lignocaine.
No, my question was, what is the 10%?
Weight by volume.
Okay, so what weight, what volume?
10 mg per 100 ml.
Okay, 100 milligram per ml. Okay.
Yes, sir.
Okay, so each activation delivers 10 milligrams.
10 milligrams of lignocaine.
Okay, then other things we need to be worried about is the toxic potential, because every activation delivers 10 milligram of lignocaine base. Okay, and there are some recommendations. Nozzles are non-sterile and single patient use only. Spray should not be used on cups of endotracheal tubes made of plastic. Its spray is probably porphyrogenic. Okay, so these points might be coming in for your Viva station. IV lignocaine preparation.
2% non-preservative lignocaine preparation.
Okay, so what's the dose for antiarrhythmic use?
1 to 1.5 mg per kg.
Okay, slow over 2 to 3 minutes. You may repeat the half dose 5 to 10 minutes, up to 3 milligram per kg total. You can also start a continuous infusion 1 to 4 milligram per minute IV after return of perfusion. Previously, endotracheal administration. This is one of the drugs which can be given through endotracheal route, but present recommendations, it's not mentioned. Okay, so you have to give more volumes, 2 to 3.75 milligrams per kg, in 5 to 10 ml of normal saline or sterile water. And the recommendation from AHA regarding the use in VF pulseless VT, we have already mentioned. Usual therapeutic drug level is 1.5 to 5 mics per ml. The toxicity might occur within this range. Usually 5 mics per ml and more is considered toxic. Okay.
Yes,
So these are the preparations we are using regularly. Which other use you can suggest for you are using for in your day-to-day anesthesia practice?
For decreasing the pressure response.
Okay, fine. One more.
If any ventricular ectopics.
Yeah, and arrhythmia use we have already mentioned.
And to decrease the pain on injection of propofol or etomidate.
Yeah, okay, fine. Okay, fine. Then you have to be thorough with the local anesthetics. We have no choice. The onset, peak, duration, the toxicity management. Bupivacaine, we have a 0.25, 0.5%, 0.5% hyperbaric. With the epinephrine is available. Isobaric bupivacaine we are using for intrathecal, and similarly for ropivacaine. Not going into that. So next station also you can take, I think. So what are the ECG features of hyperkalemia? If it is asked for 3 marks, what all things you can plan to write?
Hyperkalemia, if more than normal value of potassium is 3.5 to 5.5. If more than 5.5, we might start looking for ECG features. They generally present when it is more than 7. First starts with 7 milliequivalents per liter. First, it starts with tall peaked T waves. Then there can be increased PR interval or wide QRS complexes. Then if it is more than 10 milliequivalents, it can go for prolonged QT interval. And if it is more than 15 milliequivalents, we can have a sine wave pattern or VF or VT.
Okay. So one thing I would like to suggest, potassium being an intracellular ion, the serum values may not correlate with the clinical presentation. Okay, it's basically regarding what is the patient's baseline value. CKD patients might tolerate a higher level of potassium than a normal patient. So rather than telling about a particular serum value producing one ECG finding, when patient manifests with ECG changes, that means the hyperkalemic changes are present. Okay,
Yes, sir.
so that is one message. So with the progressive increase in values, different authors give different ranges. Okay, more than 5.5 associated with repolarization abnormalities, peak T waves appear, and as you mentioned, P wave widens, flattens. The sequence might follow the trend, but the values may not correlate. Most of the authors say individual patients, the serum potassium level may not correlate closely with the ECG changes. Patients with relatively normal ECGs may still experience sudden hyperkalemic cardiac arrest. So that is something we have to keep in mind. Okay.
Yes, sir.
When do you come across hyperkalemia in our day-to-day anesthesia practice?
Any burns patient, or if they have a history of hemiplegia or myocardial myopathies.
Prolonged immobilization.
Yes.
Okay. So such cases, what is your concern?
I'll avoid suxamethonium in such cases because suxamethonium will increase every 1 mg. It will increase by 0.5 milliequivalents of potassium.
Okay.
For every dose.
Again, that 0.5 is not an absolute value. It's an average value. It can go into higher values also. That's why we are worried about. Okay.
Yes, sir.
So at least we should have a baseline value before probably in the last resort, if we are using it for an airway concern, you should have a baseline idea about the potassium value.
Yes, sir.
Okay. So how will you treat potassium hyperkalemia? We are not going into it. We'll discuss some other time. We are running short of time. Anybody else is willing to take the next scenario? Who is with us? Lavanya Reddy, Anup? Anup? Okay, Dr. Anup is busy. So, Dr. Ashni or Dr. Chetna, you are with us?
Yes, sir.
Yeah. Okay. So you can take this question. This is critical care question.
Yes.
So with the help of diagram, anyway, I know you can't draw a diagram now. So can you explain what is plateau pressure, what is driving pressure and all?
Plateau pressure is a pressure during inspiration, during the inspiratory pause, sir.
Mhm.
And the driving pressure is the pressure required for the patient to trigger the respiratory breath.
No. Second part is wrong.
Oh, yes, sir. Driving.
Okay. So both this we come across during IPPV, positive pressure ventilation. Okay. When you give a volume control ventilation, you give an inspiratory pause. After the peak pressure, you give an inspiratory pause of 2 to 3 seconds. Then the pressure will come to a plateau or a flat phase. So that is the pressure which is actually reflected onto the alveolar end. So plateau pressure less than 30 was the lung protective strategy for some time. Okay, after some time, recently we are switching towards a driving pressure for a lung protective strategy. Okay, it is the difference between the plateau pressure and the PEEP. PEEP is the positive end expiratory pressure. That means we are raising the baseline from 0 to a particular value, say 5 centimeters of water. Okay.
Yes, sir.
If the plateau pressure is 25, if the PEEP is 5, the difference is 20. So actually this pressure difference is the one which drives the gas or air in and out of the lungs. So we are concerned about the driving pressure because we are actually trying to inflate the lung. But in a case of acute lung injury or ARDS, we may be inflating the baby lung, which is much smaller than what is supposed to be there for the patient. Unfortunately, I missed out the slide. I can't show the slide, but during our mechanical ventilation sessions, we have explained.
Yes, sir.
So rather than giving a normal tidal volume of around 450 to 500, with the lung becoming consolidated or stiff, the baby lung remaining might accommodate only maybe 200 or 250. So our driving pressure should cater only at 250 ml tidal volume. So what the studies have shown that if we can keep the driving pressure around 15, that is the lung protective strategy. So you got the idea what is plateau pressure after the peak inspiratory pressure, given inspiratory pause, that pressure value is known as the plateau pressure, which is reflected at the alveolar end. And usually we keep it less than 30. And the driving pressure is the difference between plateau pressure and the PEEP. For lung protective ventilation, we target a driving pressure of 15. Okay, what is pressure support ventilation? I'm very sorry because I forgot to put the slides. Yeah, pressure support ventilation.
Ventilation, the pressure to be supported will depend on the ventilatory settings. So it doesn't exceed that pressure. It is generally used in pediatrics not to cause a volume trauma. And also in ICU patients with...
I'm afraid you didn't get it right. Pressure support is basically, we are offering only a support during spontaneous breath, spontaneous breathing phase. Okay. We are actually, the machine is actually taking the work of the patient. That's all. Pressure support breaths are triggered by the patient. Okay. Patient will have to trigger breath. What is trigger?
Okay, sir.
What is trigger? Again, with the diagram,
Trigger is for the
trigger is what
initiation
starts
of
the
breath.
breath. Yeah, initiation. Okay. If it is a pressure trigger, 2 centimeters of water, if the patient can generate or pull the baseline 2 centimeter or more, machine senses that the patient is triggering, and it will support. It will allow the patient to take breath, and that breath will be supported with our pressure support. Okay, suppose we have kept a pressure support of 10 centimeters of water. The machine will then take the breath cycle forward. Patient is initiating, but then machine will take the breath cycle forward. And when the flow expiratory trigger sensitivity comes to a particular level, usually that ETS is set as 25%, then the breath cycles into exhalation. Okay, so each breath cycle in pressure support ventilation is triggered by the patient, and then remaining things, the cycling is decided by the ventilator. Probably if you can draw the diagram, you need to put minimum words to explain that. With the diagram, you can put arrow mark and say this is what happens at the triggering phase. This is what determines the tidal volume, because the higher the pressure support, higher the tidal volume will be delivered, and then how the cycling occurs. Okay, I'm sorry that I couldn't put that slide. So what is PaO to FaO2 ratio?
PaO to FaO2 ratio is ratio between the partial pressure of oxygen in the blood by the FiO2 percentage. Sir. Normally it is 400 to 500. In significance, if PaO to FiO2 less than 200, diagnosis is one of the diagnostic criteria for ARDS.
Okay, so less than 300, it's acute lung injury. Less than 200 ARDS, something close to 100, 150, it's severe ARDS. So we can select which respiratory support we can plan for this patient. lesser or higher PaO2 FiO2 value, there may be a scope for non-invasive ventilation support. But if the PF ratio is very less, then you have to think about straight into invasive mechanical ventilation. And again, for prognosis, your follow-up, trending, everything we can do through PaO2 FiO2 ratio. How do you find out PaO2 FiO2 ratio?
Normal PaO2 is 100 mm of Hg, sir. By FiO2 0.2. So 100 by 0.2 is generally 400 to 500.
Okay, fine. So, and only 2 more questions left, I think. So I think anaphylaxis is an important station. We cannot miss out. So management of anaphylaxis, you should be ready with. Okay, how to identify, what is the mechanism, and immediate steps, and continued care in the ICU. So anything can come in the this one OSCE or even in the Viva stations. So anaphylaxis is something you cannot miss out. Identification, mechanism, immediate management, continuing care. Okay. And critical care questions, we'll get questions like what is CVC insertion bundle? Okay. Questions like what is CLABSI and ET tube bundle. So what are ICU care bundles you should be ready with? And these answers cannot be generated after sitting in the OSCE station. So you have to have these answers prepared in advance. Okay. Then there will be questions on hemodynamic monitoring, like pulse pressure variation. What is pulse pressure variation? Fluid responsiveness. What is a fluid bolus? How do you check the fluid responsiveness? What are the indications or indicators suggesting that patient is fluid responsive? And how do you interpret this changes in the tracing, arterial BP tracing? You know, the patient is on mechanical ventilation, and what happens during inspiration and expiration? You can have a pulse pressure max and pulse pressure minimum, like that. Okay, so again, in equipments like arterial pressure transducer can be kept, and it can even appear in the OSCE stations. So what is the physical principle of invasive pressure monitoring? Who is attempting? Dr. Apurva, you can attempt. Dr. Apurva, you are with us? Yes, we are in only 2 more questions remaining. Okay, the indications for invasive blood pressure monitoring. So the principle, if you can draw a diagram that can save a lot of time, the Wheatstone bridge principle, the strain gauge principle, as the resistance changes, the resultant output intensity of current changes, and that is plotted into the graph on the electronic monitor helped by the processor. So you will get the highest value as the systolic BP and the lowest as the diastolic BP, and you will get the mean arterial pressure also. The transducer should be located or zeroed at the level of the Freibot axis. And how do you set the arterial pressure transducer? You should be thorough with the procedure of insertion of arterial cannula. The methods, what you check before attempting arterial cannulation, how do you connect the pressurized IV fluid, which fluid you use, and whether you'll add heparin, how much heparin you use, what is the idea of giving the counter pressure. And again, you may be quizzed on damping also. Here you can see the optimally damped tracing after 1.5 to 2 oscillations after this piggyback is pulled. So the values are concurrent. So this is optimally damped. Under damped is it takes more than 2 oscillations. So this overestimates the systolic pressure, diastolic pressure, but diastolic pressure may be underestimated. If it is over damped, after less than 1.5 oscillations, the tracing continues. There will be underestimation of systolic pressure, diastolic pressure, not much affected. So maybe it can appear in your OSCE questions or in the skill stations. So another scenario will be difficult airway, which we cannot miss out. Probably you may be given a scenario like this, your airway management strategy for a contracture release surgery, your airway assessment strategy, and your management protocol. So you should be, if you are familiar with the difficult airway algorithm, you can write the algorithm, which can save a lot of time, which is actually applicable to this particular case scenario given. So that is how you save time during the OSCE station. Suppose it is a case like this, a trauma patient, an obese patient with the facial-maxillary or mandibular trauma, your difficult airway management will be different. So whichever is applicable during trauma difficult airway only, you need to answer. That is the idea of giving 3 marks and utilizing the 2 minutes. You can easily write that part of algorithm. Of course, this sub-question difficult airway definition carries 1 mark, which should not consume much time. So before attempting this question, like a trauma difficult airway emergency airway assessment, you take 10-15 seconds, plan your answer, and then you can save a lot of time. So you will get, you'll be familiar with these algorithms. You can plan your answers like this. So these algorithms have been taken from uptodate.com. So I'll be sharing the PDF version of this presentation in our Telegram channel, Anesthesia Webinar Campus. So you can get these diagrams. This is for emergency airway management algorithm, crash airway management, which happens in the emergency rooms or in the ICU sometimes, where you are committed to securing the airway. You don't have an option of waking up the patient and dealing the difficult airway at some other time. And emergency airway assessment, you should be familiar with the terminologies like Lemon assessment, look externally, evaluate 3-3-2 rule, the Malapati score, you can't miss out, obstruction, obesity for O, neck mobility, whether you can position the patient in the laryngoscopy intubation position. And Makocha score is very applicable in an ICU scenario, especially the patient is critically ill. You don't get enough time to invest on airway assessment. So you have to have a quick assessment, Malapati score of 3 or 4, obstructive sleep apnea syndrome, this is the A part of it, reduced mobility of cervical spine, this is the C, limited mouth opening, O, less than 3 centimeter. You can see the weightage. Malapati score and obstructive sleep apnea carries good weightage. Malapati score 5 points, OSA 2 points, and rest everything 1 point. And if patient is already comatose, 1 point, severe hypoxemia saturation 80% or less, 1 point. And if the operator is non-anesthesiologist, again it scores 1 point. So it's scored from score points of 0 to 12. 0 is easy, 12 is very difficult. If all the factors are there, you have to anticipate difficulty. In emergency critical care, the immediate airway management, if the routine measures are not working, would be to go in for a front of neck access. That procedure also you can get familiarized. You may be asked about that. How do you plan for a front of neck access in case of an emergency in a critically ill patient? Okay, again, one more message I would like to give is after 7 stations, you get again breathing space. Okay, again, if you count 5 minutes, it's more than enough time for you. So you don't think about what had happened before in the previous stations, whether I got it right or wrong. Don't spend time on it. Don't think too much on what's going to come, because your anticipation will only cause the release of stress hormones in you. It's not going to keep your brain cool. So just avoid the stress hormones production. Say goodbye to stress. Relax for 5 minutes. Be cool. And during any time during your exam, right from the morning, my personal advice is to have a good sleep the night before the exam. Go fresh into the exam hall. You have all the instructions. You follow the instructions. I think in this particular COVID season, the invigilators, the helping faculty, and the staff is going to be more considerate to you. So don't be afraid of that. I think National Board has taken enough and more precautions to make the conduct of the exam very smooth. So it doesn't warrant you to press the panic button at any time. Be cool. That is the mantra, the magical word to give the best output. Maybe 2 or 3 years of training period, you have seen so many things, you have attended so many classes, you have read whatever you have read, it should come out. The output comes from a cool mind. So that is my advice to all my dear friends. Be cool. Don't press the panic button. And whenever you feel I can't do it, cut out one portion of it. That's the idea of taking the magical word in our professional exams. You believe in yourself. You say, I can do it. All the best, dear friends. I think for all those who are taking the exam on the coming Tuesday, that is the 21st of July, I wish you all the best. Our advice from Webinar Campus is to be cool, because during our curriculum, definitely you have heard about so many things. Whatever you have heard should come out at that particular time which matters. So once you keep your cool head, you can expect the best outcome. So you get prepared for that. We will continue our webinar campus programs for critical care and anesthesia and all the acute medicine specialty, subspecialty. Tomorrow also we are having a session planned on breathing circuit. Dr. Gopakumar is leading the lecture tomorrow. He's a senior consultant in Anandapuri Hospital, Trivandrum. We'll go live on our webinar at 7 o'clock Saturday. We'll have a demonstration of all the breathing circuits. We have kept all the equipments ready even today. So we hope we can have a smooth run of breathing circuit demonstration. We are trying our best to make it more effective. I know many of my friends are taking exam in the subsequent weeks also. So those who are preparing for Tuesday, if you have time, just visit our webinar, or when during your free time, you visit our YouTube channel. Definitely you will benefit from that. Dr. Anup, your concluding remarks?
Best of luck, friends. And again, I'll try to include topics from critical care also to the OSCE sessions, especially CPR, toxicology, electrolyte imbalance, ABG, ventilation, all those things. So we'll include OSCE part from those critical care sessions as well. So all the best. And again, I'm welcome to, after clearing DNB, welcome to critical care. You can join for DM or DNB critical care and can continue to be with Webinar Canvas.
Okay. As student or even as faculty, you are welcome. Okay. Okay. Once again, a very warm greetings and all the best to all the exam going PGs from Webinar Campus. It's the good night to all. Thank you for being with us.
Okay. Thank you. Good night.